This is a video presentation on lateral femoral condyle osteochondral allograft and concomitant lateral opening wedge distal femoral osteotomy in the setting of failed osteochondritis dissecans fixation. The disclosures for the senior author are listed below. The patient is positioned in the supine position on the operating table and induced under general anesthesia. An 8 cm lateral incision is made over the midline distal lateral femur for the DFO. The iliotibial band is split, and the vastus lateralis musculature is elevated to visualize the femur. An anterior incision is made from 6 cm above the superior pole of the patella to the tibial tubercle. If the patient has undergone a previous arthrotomy, the existing incision may be utilized. Careful dissection to create a lateral parapatellar arthrotomy is performed. The knee is flexed to improve visualization, the patella is retracted medially and held in place with Z retractors, and the osteochondral defect is identified and measured. The identified defect margins are first scored. Copious irrigation is used while the osteochondral defect is reamed to prevent iatrogenic heat necrosis. The depth of the recipient site is measured along the points of a compass. The fresh donor graft is measured to the exact size of the recipient site. Care should be taken to attempt to match the expected contour or anticipated radius of curvature of the recipient site. Once the donor graft is harvested, the depth should be cut to match the recipient site. Prior to implantation of the graft, pulsatile lavage is used to remove the blood products from the subchondral bone of the donor graft. The donor graft is inserted into the recipient site, ensuring the transplant cartilage margins match the level of the native articular surface. Due to odd shapes of osteochondral defects, several osteochondral plugs may be required to optimize the osteochondral allograft resurfacing. Smaller plugs can be placed using a snowman technique. The arthrotomy is then closed with orthocord. The previous distal lateral femur incision is used for the lateral opening wedge DFO. 2 guide pins are placed at a 45-degree angle to the adductor tubercle and perpendicular to the femoral diaphysis along the lateral femoral cortex. An osteotomy guide is placed between the pins, and an oscillating saw blade is used to drill to a depth of 5 mm following the trajectory of the guide pins. Osteotomes are then used to cut the bone to the medial cortex, where a 1 cm cortical hinge should be maintained. A finger should be used posteriorly while the small osteotome is being advanced to protect the neurovasculature of the knee. An opening spreader device is placed into the osteotomy cut and held in place for 5 minutes to allow for stress relaxation of the medial cortical hinge. A distal femoral poodoo plate, sized to fit the desired osteotomy correction, is placed with 4 4.5 mm cortical screws proximally and 3 6.5 mm cancella screws distally. Fluoroscopy is used to confirm the desired screw trajectory and plate fixation opening of the osteotomy. The tourniquet is let down, the deep and superficial tissues are closed with sutures. The knee is placed in an immobilizer in full extension.